Hello, everyone. The Maryland Healthcare Commission thanks you for joining the Telehealth Policy Workgroup. My name is Ava Lamar, and also joining from MHCC, our Executive Director, Ben Stephan, as well as David Sharp, who questions.
So, Ava, can I pause a moment? Is Justine, are you having trouble hearing her as well?
Yes, I can
Yeah,
take over if you would like.
yeah, she's going in and out. Something's not right with the microphone. She is going in and out.
Okay. Ava, I apologize for that. So, Ms. Springer, if you're able to carry on, could you do so?
Sure. So hello, everyone. The Maryland Healthcare Commission thanks you for joining our telehealth policy work group. My name is Justine Springer. Also joining us today is our Executive Director, Mr. Ben Stephan, as well as David Sharp, Ava Lenore, and Christine Karianopoulos. Due to the number of people on the call today, we will not be conducting individual introductions. The list of participants is available on the MHCC Workgroup webpage if you would like additional information. MHCC staff will take attendance by recording the names of those attending via the Zoom web link. If you are calling into the meeting, we ask that you please email Christine Karianopoulos to confirm your attendance, and her contact information is on the agenda. Now I'd like to cover some housekeeping items. This meeting is being recorded. The recording will be available on MHCC's telehealth webpage. In the event that there is a meeting disturbance or hack, we ask that everyone please hang up immediately. And Ava will send a new meeting link via email to everyone in the distribution list with instructions for how to join the new meeting. Please make sure that you've joined the meeting either via web link or by the phone. Connect your audio through only one medium to avoid any feedback. All participants are muted upon entry. You are able to mute and unmute yourself using the small button at the bottom of your screen that looks like a microphone, or by entering *6 if you're joining by phone. It's best to keep your line muted until you are ready to comment to avoid any unintentional background noise. MHCC staff may mute you if there is a lot of background noise coming through. If you are having any issues with the technology, you can email, call, or text myself, and my contact information was in the email sent on Tuesday. You can also use the chat function to directly message me. MHCC staff will sequence participants who wish to speak. Signal to the MHCC team if you would like to speak by using the raise hand icon next to your name, and we will call on you. We will also provide time for those of you on the phone who aren't able to use the raise hand function to comment. Participants are welcomed to use the chat function as well, but please note we will do our best to read comments in the chat box. However, there may be too many comments for us to get to all of them during the meeting. Comments will be reviewed by MHCC staff prior to joining the next meeting. MHCC staff may request certain participants to comment on occasion to ensure there is a range of perspectives represented. A link to the meeting materials was emailed to you on Tuesday, and I included this in the Zoom chat if you need a copy. If you are joining via the web, the materials will be displayed during the meeting. We do encourage everyone to have the information grids open on their own screen as well. I'm going to pause here to turn it over to David Sharp, MHCC Center Director for Health Information Technology and Innovative Care Delivery.
Okay, thank you very much, Justine. And again, welcome everyone. We have quite a large group with us today. I believe we're somewhere in the neighborhood of the low 50s in terms of our count. Before we get started, I would like to recognize two people. The first individual is Dr. Bhandari. He is a distinguished physician and one of the Maryland Healthcare Commission's commissioners. So we're grateful for him taking time out of his busy schedule to join us today. I would also like to acknowledge Mr. Levon Ward. He is the mastermind behind keeping all the technology up and running for us and helping us coordinate this event. So behind the scenes, he's sort of like the the Wizard of the Oz, if you remember right, where everything just seems to work. So, and I also appreciate my team, Miss Ava Lenore and Miss Springer, Justine Springer, and Miss Karanopoulos, who have also joined us today. So for those of you who were able to join at a prior meeting, and we left everybody with a bit of a homework assignment, and that was to provide input on these information gathering tables or grids, as we often refer to them, which is very fundamental to a SWOT analysis, where it's divided into 4 sections. And what we do is we look to gather content from the individuals. And Ava, why don't you go ahead and pull that up for the moment, and let's let everyone see what I'm talking about. When we began our discussions at the last meeting, mostly the tables were just blank. We had some information which we were able to collect during that working session. So today is really, again, a roll up the sleeves working session. We don't anticipate leaving this meeting with anything more than much deeper digging into the content and perhaps some common themes that we see. We want to use today to look at each one of the 6 different policies that we identified for discussion, thanks to you all, and then look at the elements in the quadrants, in these 4 quadrants, to see if we're missing anything. And if we're missing something, we'll add it. And then, time permitting, we want to come back and look at common themes. And that is common themes by quadrant, because that will help us then common themes overall. So we start with steps, and you will see the great work of so many people that added input to these tables. And I think you'll be very impressed with at least where they are today. So with that, let me pause for a moment to see if Justine, were there any more comments that you were planning to make, or are we good to go?
Good to go. That pretty much, I think, covers what I was going to cover with regard to the grids. So I think that we can get started with the grids.
Very good. So the typical process is I'll sort of tee it up, and then we'll turn it over to you all for comments, for additions. And as we look at this, we have to wear 2 hats. We want to wear the hat of the stakeholders that we often work either the closest with, or that we're aligned with. And we also want to wear the hat of sort of the independent reviewer. You know, what's here? What does it look like to you? Does it make sense? Should we add something? Should we take something out? And Ava will be adding and deleting and making changes on the go. So we tend to modify on the go. So let's see how this works. And we'll start with the very first policy, which is removing telehealth restrictions on the originating site. That's the discussion item. And we asked everyone if they would provide us information for each of these quadrants. So if we think about it from a general concept, removing telehealth restrictions on originating sites, and we look at the benefits of it by providers and consumers. So think about it this way. What's here, does it, under the providers, benefits for providers, does it adequately reflect what the benefits are? So let's pause for a moment and see if everyone can take a few moments to read. Hopefully the folks on the phone have access to the materials. There's a lot to read, and I can read them individually, but it will just slow us down a lot. So let me give everyone a chance to read the provider section. And Ava, why don't you just sort of highlight the provider section? Okay, so if you can, we'll limit our focus there.
David, I see that Ben has joined us. If you wanted to ask him if he wanted to say anything at this time.
Wonderful. Let's allow our executive director to make a comment if that's his preference.
I arrived late, so I yielded my opportunity to say too much at the outset. I want to thank everyone for joining. And I think that this is an important meeting as we begin to think about how telehealth is going to evolve. It's hard to say post-pandemic when we're in the midst of a major increase in cases, but I think we want to take the longer view in this entire effort and think about what's practical for the future. So thanks a lot again for everyone attending.
Okay, thank you, Ben. So let's come back to our provider section. So the question before us now is this list adequately represent the benefits to providers? And if it doesn't, what should we add? And if you think there's something there that doesn't really fit, let's call that out. So we'll open up the floor for thoughts at this stage and see if anyone wants to weigh in.
David, this is Dr. Bhandari. So potential decreased cost associated with brick and mortar facilities, what does that really? That means patients are not going to the hospital, emergency room, or urgent care. That's what it means?
That's correct.
I think one thing I want to add more, a lot of time during COVID, we want to minimize the exposure. A lot of times, like our patients get admitted in the hospital. Rather, everybody going in the hospital, I talk to the team who's providing care. If telemedicine can be expanded to that will be very helpful. I spend a lot of time. Especially when the cases go up, I try not to go unless it's must, because I can provide a lot of them help about the patients remotely.
Very good point, Dr. Bhandari. Thank you. Other comments? Jean, your thoughts? Okay, he may have stepped out for a moment. Rebecca, do you want to weigh in?
I was looking at the whole piece, and so I don't see benefits for payers. I don't know if we want to put payer benefit here.
So it's a great point. Why don't we add that section? The what you see here before you, just to remind everyone, is the information that was provided via the quote-unquote workgroup homework. And we did not get any feedback from anyone for this category, but perhaps with everyone having a chance to give it some thought now, we might have some information to include. It's a very good point.
Right. My question is probably around Medicaid. I know they pay for transport for some of their chronically ill patients. And so would telemedicine lower those transport costs is an opportunity, but Medicaid would have to weigh in.
Sure, that's an opportunity. Why don't we add it, and I can ask Tricia if she could give it some thought, and we'll come back to this point in just a few moments.
Yep.
Let's see if we...
And David, I'm sorry, I just was not efficient with the mute button earlier when you called on me, but I have been here and listening. But I'm fine with everything the way it is.
Okay. Wonderful. Thank you, Jean. Other comments here to the provider benefits?
David, Karen Merkin has their hand raised.
Karen, please.
Hi, how are you? Yeah, this is Dr. Corinne Merkin. So one of the things I didn't see here is the increased communication between providers. So provider to provider communication, which is also a telehealth benefit and I think is underutilized.
It's a very good point. Great point. Okay. So it seems that we've fairly well covered this section in terms of the actual benefits for providers. If there is nothing else, we will move into the payer section. But before we travel along, I need to take a moment to just confirm that's the case. Justine, anyone wishing additionally to weigh in here?
No one else has their hand raised, so.
Good afternoon, it's Kathleen
Hey, Kathleen.
Loughran with the Group.
Good afternoon.
How's everybody? I know that the MCOs did provide some input recently.
Okay.
So this section on pairs may need to go back and be populated based on those comments. Some of our concerns,
Now, are these because we're looking at, Kathleen, at just the benefits for the moment. And I think
I thought that the MCOs, we may have been late with our comments. I thought we had provided some.
okay,
I think access was one.
is that a benefit?
Access for members.
Okay,
Access for members.
sure. So we can add that under the payers. Good point.
And David, benefit of the payers is avoid as it's a benefit for the provider. Same way, avoiding unnecessary utilization of emergency room, urgent care facilities. You know, as a physician, because I know my patient in and out, I know where they should go. A lot of times we give them hydration, or we can provide those services in a low cost facilities like our office, and we can do a better job rather than sending to somewhere where patients are not known for their medical health.
That's a good point. So, Ava, do you want to try to capture that? I think it's more along the line of care delivery at lower cost, and why don't we just say at lower cost and most efficiently? That's probably good.
That's for the payers also. You know,
Yeah.
that's a benefit for the payers also.
And agreed. So thank you. Kathleen, was there additional for the payers here in benefits that
I think that was probably the overriding issue for us. I don't have the list of comments in front of me, but I believe greater access for members, and of course, lower cost setting when appropriate would be another benefit, and you've covered that here.
Okay. Very good.
Thank you.
Yes, indeed. Let's keep traveling on. Are the payers?
Jennifer Witten had a comment or has her hand raised.
Sure, and then I think Sally Alborn would follow. But Jennifer, good afternoon.
Hey, David and team, thanks so much. I guess my comment is just to remind folks, this is more related to the benefits of a patient. Just to remind folks that previous policies required patients to go to an approved site to receive telehealth services. So there was a lot of limitation in terms of accessing services in their home or other appropriate location. So, you know, I think for this space, it really obviously increases access, which we've talked about, but it also adds flexibility in terms of that patient location. So whether that patient's at home or at work or some other appropriate location, it just adds that flexibility to really receive care when most needed.
Okay, thank you very much. Appreciate the input. Ava's adding it as you speak. Sally Ann.
I just want to say, Kathleen had greater access for members, and maybe the flip side of that is to decrease for payers the number of unengaged patients or members.
Okay, very good. And I would like now to invite Trisha Roddy to.
I think you guys, I mean, it covered it already. I mean, I will say that we have looked at transportation costs before in our evaluations, and we really haven't seen any considerable savings around transportation. So I think it's always good in concept, but we have never seen any realized savings around transportation. But obviously, you know, it's greater access for members. Again, you know, if you're engaging members more, again, which attributes to the increase in access. And if you can get it in the more efficient setting, then obviously. I don't think we've ever looked at the studies to show that we do get it in a more efficient setting now.
Okay, good, thank you. Additional comments related to the benefits for payers here? And Justine, anything in the chat that's relevant to the top to this section?
Nope, no hands raised, and the only chat was from Rebecca, who already spoke.
Okay. All right, so let's look a little deeper. I think let's travel into the consumer area, and we'll pause and give everyone a chance to read. And then I want to invite some of our consumer representatives to speak. Perhaps Ellen Weber, we could get you to start the conversation off in a moment.
Hi, David. Thank you. Sorry, apologies. I was trying to get this unmuted.
Afternoon.
Good afternoon, and hi to everybody. Thank you for putting all this together. These all look like the issues that we've identified as to how this is, why this is important to address the originating sites. And as Jen was saying, particularly to give attention to being able to have services delivered in a patient's home or in a location in which that patient is comfortable in having services delivered.
Wonderful, wonderful. So other folks on this webinar here, any additional reactions, thoughts?
Hi, it's Lori Doyle with the Community Behavioral Health Association of Maryland. Just want to add that for a lot of people seeking behavioral health, whether it be mental health or substance use disorder services, there's still a lot of stigma attached. And so to the extent that you can get services in your home or someplace where you feel it's more private, that may encourage people to seek treatment who otherwise may not have wanted to go to a facility.
Very good point. And who might be able to help build on that a little bit? Oleg, can you weigh in here as well?
Yeah, absolutely. I couldn't agree more with what Lori just said. For a lot of folks with behavioral health needs, sort of this perception of how society views you in terms of sort of weaknesses that are associated, as wrong as they might be, with behavioral health issues. And so if you're able to receive services from your home, and the only other person that you're exposing your, again, what folks perceive as weaknesses is that could facilitate a lot more people initiating behavioral health services, at least to get assessed and diagnosed, and maybe they will engage in further treatment, or maybe just ends with that initial appointment. But as Lori said, it will definitely allow for this other avenue for folks to just start the conversation. I guess as a clinician, and most of other providers on the call probably can relate to this, when patients make a decision the very first time they see a clinician to go out and tell somebody about some of their deepest, darkest secrets, it's a move of courage and bravery. And so as much as we can remove the barriers that stand in the way of someone being able to start that conversation, I think it would be helpful.
Yeah, that's a good point. And I think Rebecca had a pretty good point. Rebecca, do you want to share it with the group? Some people may not be able to see the chat.
Sure. I just wanted to point out, do we want to have infection control in here and safety? It's going to be a topical subject for a long time.
Yeah, good point. And Jean, do you think you brought up something very good for us to, if we could digress back to?
Yeah, so, and I run the equip meeting, so we're working on these different value-based models, and a lot of them, there'd be a benefit in making sure that telehealth was effective, because it could be a way to make those value-based payment models and incentivize. Particularly, I could see in several bundles where that could be a positive thing if we could include that in, or allow it as a way of doing certain checkup visits and maybe reducing costs. So I think there's a connection there that is just something we should note or comment on.
Yeah, good point. Let's add that under payers, Ava, when you get a moment. Dr. Brandt, you deal a lot with consumers. What are your thoughts here?
Yes, thank you, David. I'm trying to get my video to work as well. Can you hear me?
Can hear you. Welcome.
Yeah, no, we just actually, we're just getting in the midst of teaching a class for our consumers in our West Baltimore community. So I stepped out of the classroom a little early because this is so important. But I would have to say, to the discussion of removing barriers and improving access, but just being mindful of connectivity issues and some of the digital disparities. So I just, for all of us as providers, there's definitely wonderful ways, but there's still people who are having access to these resources. So continuing to persevere as payers and providers to advocate for our consumers to get low cost access that's private. And I know the city's doing efforts on that, but it's still something we need to continue to work on. But I think generally many consumers, and I work, for those of you who don't know, my practice is primarily with older adults, is sometimes there's a little bit of sensitivity to, them feeling comfortable getting on some of these platforms. So I think we need more training programs for our consumers too. We were actually just talking about that yesterday as part of our work because older adults may or may not understand the Zoom platforms and technology or what these web links are and things like that. So simplifying it. And again, I know there's efforts in that area, David, but I think again, as payers, providers, making it simpler for our consumers. So thank you for that opportunity. But we're learning on the go. As I say, we're building that plane, David, while we're flying it here. So
Understand. So let's bring in a different perspective a bit. John Cornack, John.
David, can I add one more for consumers?
Dr. Banderi, please.
So, it's good for the consumers. They don't have to spend time in traveling, coming to the office and take time from their work. Already people have difficulty at getting back to the jobs. So it's really saving their time. And I have patients, sometimes they are at work. They want to have a televisit. They go to some private place and they just do a televisit from there. It's a lot of saving their time. And sometimes I say, I have to look at the labs and certain things. I really don't want them to be there physically. It's a great convenience and, good continuity of care for them also.
Wonderful. Thank you, Dr. Banderi. Also, I failed to introduce another distinguished commissioner that we had joining us today, Dr. Akindade. Good afternoon. Thank you for joining us. We appreciate you taking time out of your busy schedule as well. There's an opportunity here. You have a pretty strong background in working with technology, so we'd be curious to know your thoughts from the consumer perspective here.
Thank you very much, and I'm excited to be here for everyone. I'm Bim Akintade, and I think, we've actually done a pretty good job in terms of comprehensively addressing this. The one thing that sort of kept popping into my head as some of the comments came up was the benefit of compliance for a lot of our patients, and not only for the behavioral health patients, but also thinking of our younger patients who don't necessarily want to sit in a hospital space or, go through the transportation to a hospital to sit with a healthcare professional. As we know, these days, if you are starting a business, if it doesn't fit in the palm of your hands, you should probably rethink that idea. And so now we're sort of transitioning that into healthcare, and I think the telehealth initiative also addresses that. So that was, I just kept thinking compliance and improved compliance with telehealth. So,
very good point. Thank you again for joining, and thank you for your comments. John, are you able to weigh in? John Cornick?
David, I got here for not really wanting for you to ask me to comment on. So if you could just ask the question, I'll make sure I can provide some proper comments.
Sure. We wanted, from the perspective, why don't you tell everybody who you're with and see about if the perspective on consumers that you might have.
Sure, definitely. John Cornack, I'm a senior solution engineer. I'm part of the solution design team at Amwell, formerly American Well. So obviously with COVID, we had a lot of, even prior to COVID, we had a lot of different opportunities with hospitals and health systems that were doing a lot of direct-to-consumer, but either it wasn't really being taken advantage of properly, wasn't being reimbursed, or there really wasn't marketed. But obviously with COVID, everything pretty much shifted on a dime, where solutions were going from in-visit and clinics to virtual care. So we've seen numbers here at Amwell and really across the United States really go to 700%, 3,700%. It really kind of all depends. And we're also seeing more and more providers who are basically being onboarded into these platforms. So we feel that this really isn't going to slow down or change. It's really just going to advance the adoption even more for not only for the hospitals and health systems, but for patients who are really not only requiring this, who are basically saying we need to continue to do this just because a lot of the limitations and just the surgeons that have kind of come up in different areas.
Very good, thank you. And we have a couple of comments that we probably should call out. Ann Horton, do you want to share with the group?
Sure, I just added into the chat earlier the benefit of saving, what for some providers is precious and costly PPE, particularly in the home and community-based services arena. It continues to be a significant struggle.
Yeah, good point. Thank you. And Vivian Aguilio, I think you bring up an interesting point for payers. Perhaps you can share that with everyone.
Hi, yeah, it was just a quick comment, just that at least with insurers, keeping the insurance pool, and this became very real, with the Affordable Care Act, just the idea of growing the insurance pool and really just having younger, healthier people in the insurance pool to keep costs low for everyone. And it's also a constant struggle because usually younger, healthier people think they don't need insurance. So, offering access like telemedicine could make, having insurance, having regular healthcare visits more attractive to the quote unquote young invincibles.
Wonderful, good point. Thank you. So we have quite a list here amassed under the benefits side. We probably could move on unless there's anything you think in this quadrant under benefits that's missing. And I can pause for a moment just so everyone can do a last read. And then otherwise we'll go on to the unintended consequences. Okay, Ava, if you can scroll up a little bit there. Okay, so let's take a moment. We'll follow the same process that we have done in the first 20 minutes or so of our discussion. And let's talk a little bit about the unintended consequences. So we're going to first start with providers. And, I would invite the providers to want to weigh in here. So I can ask a few folks if they would wish to start. Dr. Bandari, are you able to comment here?
That is true. My concern is ability to accurately diagnose. Personally, I think certain subspecialty, it would be hard to accurately diagnose. That decision has to be up to provider. Because during COVID pandemic, I have seen where patient doesn't want to, although they have seen a physician, but they don't want to go for further testing, that can sometimes compromise in the care. So I would say provider has to make that decision.
So
and risk of privacy and security of PHI, I thought that was kind of waived. Can somebody elaborate that?
So the notion here from, and for anyone who might have commented, please weigh in on this one, but I recall that the thinking, it sort of borderlines on the technology that's been made available through the relaxation policies of the Office for Civil Rights. And so the concern happens to be is how secure is the information when you're using when you could use technology that doesn't have to meet minimum requirements set in standards for privacy and security. So I think this kind of overlaps a little bit into that area, which is I think policy discussion question number 5 that we would get to later, either today or at the next meeting.
One thing is this potential loss of local provider and services. I will put in a different scenario. When I was on board of physician, we always have the discussion about telemedicine because they were working on that. My concern was a lot of times, venture capitalists, big companies, they want to capture this market. They may be out of state. There is no establishment of patient care relationship. My recommendation was at least there should be one in-person visit when you know the patient, when you know how they look like. Otherwise, it's going to be a very, very difficult scenario. We try to put a stop on narcotics, which medication they can do it, because it gets very, very difficult. Patient call out of state providers, they don't even know them. That can be very tricky.
Oh, very good point. Thank you, Dr. Bandari. Dr. Berman, any thoughts here as it relates to providers, unintended consequences?
So thank you very much, of course. So I'm actually on the wrong, there we go, thank you. I think we covered it well. I really don't have a whole lot to add, so I appreciate it. I don't want to take up unnecessary time. Thank you.
No worries, thank you. Jennifer Witten, thoughts?
Yeah, David, I think some of our thoughts here was just, again, the patient needs to determine, what's the best location for them. But we recognize the fact that, if a patient is at a location that other people are at and or at work or, those kind of circumstances that, information might be shared more broadly. So it's just really ensuring that to the extent we can, that consumers have that, protection when they're having that consultation. Because again, this would be at the patient's location.
Good point. So I think we have a few other physicians represented here on the call. Anyone wish to weigh in here that hasn't weighed in?
So I'm a provider. I'm an acute care nurse practitioner, another physician. But another thought is something that we're experiencing in the academic environment. Due to COVID, we had to make a pivot, significant pivot from brick and mortar areas of comfort to the virtual space. And one of the things that we all assumed to a certain extent was, even though we've always used technology as part of how we conveyed information to our students and how we've taught in the classroom, that everyone would be comfortable with the use of technology. So I feel we're also making that sort of blanket assumption here that all providers are also comfortable, with the use of technology and would be able to deliver telehealth and the same, connections with patients and the ability to accurately diagnose. I agree, is quite vague because that's a significant part of that interaction with the patient. Utilizing technology can, create a significant, issue, in that situation if the provider isn't, astute in their use of technology while, seeing patients through telehealth. So that's something that I think is significantly important.
Dr. Akintayev, that's a very good point. Thank you for bringing that up. Dr. Brandt?
Yes, David? I think that was an outstanding point and is something we shouldn't assume in terms of providers aspect. I think this is a really great list. I think someone chatted into the box just of consistency of providers and how they share that relationship. So, so I think just making sure we have effective communication and consistent communication is going to be important with this telehealth angle as well, and the exchange of that communication.
Very good. Are there any other unintended consequences for providers that we haven't recorded in your views?
David, I was going to follow on a point that came to mind after Dr. Akintada spoke, which is we really don't necessarily know what the impact is of telehealth on training of clinicians. I think you can make the point that it might be improved. I think thinking about my own personal exposure with being treated and seeing several residents accompany the attending, that telehealth could complicate the training arrangements that we have. It could also, but I don't think it's clear exactly that would be the case. It could also benefit it, but the impact on training is something that we have to pay attention to. I think also, just as we're thinking about this, remember everyone that we're talking about this post-pandemic, sort of what the world will look like as we come through the crisis. That really, what we're seeing today, what's happening today, is not likely to change for some time. So looking at a new world in terms of what that ought to look like, I want to emphasize everyone should keep that in mind.
Yeah, very good point. Thanks, Ben.
Dave?
Ben, Stefan.
Yes, go ahead.
Yeah, I just wanted to follow up on that. To the point about training, there really has been a lot, and I'm happy Jen's typing in. University of Maryland's been doing a lot in this space in terms of partnerships with some of our training programs.
Yes.
Yeah, so we have learned a lot and can share some of those experiences too.
Yeah, that's great. Yeah, the opportunity to work with Dr. Neil Reynolds quite a bit over the years, so we're appreciative of all his help. So Rebecca, I feel like I should call on you just because you are such a telehealth guru in this state, and I'm constantly looking to you for policy information.
Okay, for policy, I just want to, can I add for training? So Hopkins is developing clinical training by specialty for providers to conduct exams via telemedicine. So just keep your eyes open for that.
Okay.
Hopefully it'll just pair nicely with University of Maryland's. That's great.
Right.
So what would you like to talk about for policy?
Oh, I think you're doing good. Is there anything additionally that you would add for the providers' unintended consequences from your experience?
I think the only thing I put in the comments, and I need to see if it's on here already, for an unintended consequence for providers, is that it makes it very difficult for them to not have one path of patient care, in that who's covered, who's not. They really want to avoid patients having to self-pay. They don't want to pass that burden on to the patient. That really doesn't fit in here, but I don't know how you could massage that, but
We'll record it and we'll smooth it out at
yeah.
So thank you. Before we travel out of providers to payers, just want to give everyone another chance to look to see if this list is comprehensive. And Jean, you always bring a good perspective, so I don't know if you're able to weigh in here or not. Okay. Anyone else?
David, I'm going to repeat the question again. If this is going to stay post-pandemic, I think where the provider is located, are they located in state? Are they providing continuity of care, or they are doing one-time visits? That is going to be very, very important for patient care. If it's one-time visit only, like many insurance companies do, they are trying to do, provider is somewhere in Arkansas or they are in Arizona, that's very different. Every visit for them is a new patient, which is very difficult. Continuity of care is very easy with the telemedicine.
Yeah, very good. Thank you, Dr. Bandari. Okay.
Sonia Lawson had a comment she typed in if she wants to.
Sure. Thank you. Dr. Lawson?
Yeah, I just wanted to let people know that in terms of the training aspect, at least from students, that I know in our accreditation standards it's already included. I'm not sure in the other of the providers' accreditation standards, it's already part of entry-level practice. It's just that now that we are able to do it in real life versus simulating it, which we had to do before COVID. So.
Very good. And I think, I skipped over Sally Ann Alborn before. Sally Ann?
No comment. No additional comments. Thank you.
Very good. Let's move on to the payers in the unintended consequences. And perhaps I could invite Tricia to start things off for us.
I think just overall, you've got it listed already, the potential for overutilization. I think for all the reasons that the providers cited above show that there are probably potential issues around quality of care in some instances and settings. And then, which it's a bit unique to Medicaid, but we tend to cover a broader range of providers than some of the other payers. So, for example, we cover settings, residential settings, which is again a bit different than other payers. And in those settings, moving the originating site might not make sense. And so we need to be careful about broad language around just removing originating sites, given that the benefit structure in Medicaid is again a bit different.
Good point. Thank you. Kathleen, are you able to add comment here?
Yes, thank you. I think what I would add is the concern for delivery of partial care, because some care would need to be provided in person.
And we did, I believe Deb Rifkin was going to join us, but I think there's someone on the webinar who...
Hi, David. Hi, David. This is Kathy Grayson. I'm Deb's Director for Government Affairs.
So we're getting background. I think it could be from your computer and your mobile phone. Levon, and perhaps is it simply just muting her phone?
Is this better?
Yes, it's muting one or the other. Yes, that's much better.
I'm so glad. Sorry about that. So the feedback that we provided, CareFirst actually supports removing originating site restrictions. We don't have such restrictions today, but the feedback we provided, and I guess this is an unintended consequence potentially, but we just think that no matter what the policy decision is, we should take a look at quality and cost going forward and sort of analyze, how this plays out.
Good point. Thank you. Jennifer, I think you might have some comment here. Jennifer Witten.
Sorry, David, to what?
To the payers to hear unintended consequences.
I think that we need to continue to monitor quality and patient outcomes as we deliver care face to face. So I wouldn't say that I would argue with that. I think, again, we need to give clinical discretion to allow providers to use the tools at hand to deliver care. And sometimes telehealth is the only option. So I think that's important. I would love to see data from the payer community that demonstrates, additional cost or overutilization. So far, our data indicates the opposite of that. I think in terms of avoiding high-cost healthcare settings and reducing hospital stays, we've seen some value in that. Of course, the pandemic has offered a new experience, so we have a lot to learn there. So I think, you know, again, I hope this group continues to look into these issues, not just during the legislative session, but beyond the session, and how we really think about as we move as a state forward in the future. So I guess that's just my general thoughts.
Yeah, thank you very much.
Hey, David, this is Matt Celentano from the League of Life and Health Insurers. Hi, how are you? I would love to chime in a little bit on behalf of some of the payers. The commercial carriers don't seem to have as much of a concern with the originating site. I think this is more a issue in the Medicaid space, but I will agree with my colleague Kathy from Care First that we have heard of some overutilization of health services, but more to the broader point, anybody who tells you exactly what has happened in the last couple of months, I think is leading you down a road that is not necessarily the full picture. There is no way that we could have enough data in the midst of the state of emergency and the panic to have an idea of really how well some of these programs are working and not. And there are a lot of other concerns than just the originating site. So this portion of the program has been really interesting, and there are a lot of great perspectives, but I feel like we've gotten a lot broader than the originating sites here. For example, there was a discussion a little bit earlier about how insurers are consistently sort of motivated by young invincibles and trying to get young folks into the risk pools. Absolutely, that's good for everybody. A lower morbidity rate with younger people who are healthier and don't utilize as many services is going to lower costs for all of us. Telehealth is not going to be a motivating factor at all for them. The only thing that's going to matter is the price. So it is a good discussion to try to get as many young adults into the risk pools. We had a different discussion with that with the exchange earlier today, but I think it has nothing to do with telehealth. So I just wanted to put that out there. But there are a lot of other factors that we can talk to as we get going on some of the different aspects of this policy, but I think it is extremely premature to say what has absolutely worked and what has not worked. We have seen a dramatic increase in telehealth claims like we have never seen in the history of telehealth. It has dropped off significantly, and it's probably going to go explode again as we see this incredible surge that we're all going through. So everybody is rolling with the punches, all stakeholders, and we're just going to have to sort of weather this storm. And I think trying to make a sweeping change in the midst of the madness serves nobody any good.
Good point. Thank you. Dr. Akintada, were you going to say something?
No, not at this point, just listening. And you're actually really close. My name is pronounced Akintade.
My apologies.
You're close.
Now I'm blushing in front of 60-some people. Okay. So let's travel along to consumers. So questions, comments here from the group. And we have quite a bit of number of consumer reps. And perhaps I can invite Jim Gutman from AARP to start us off here. And this is Unintended Consequences.
Sure. I think what you have in the summary certainly reflects AARP's viewpoint. AARP is a strong proponent of telehealth services and their expansion, but the one caveat that's been mentioned before and I think needs to be emphasized is particularly some older people are just not comfortable with this, and they should not be dragged kicking and screaming if they really don't want to do this. And that needs to be part of any policy that we develop.
Yeah, that's a good point. Thank you. And Ellen, are you able to weigh in?
Yes, and I mean, the only other point, and it ties in again with what Jim had just said, I mean, there very well may be pressure placed on a consumer to do a telehealth appointment, take that as the appointment as opposed to taking having an in-person visit. And, you know, that very well may be sort of also doing a telehealth appointment with someone who's not qualified to provide the service that is needed. And so, again, impresses upon me the need to really make this a consumer choice, obviously, in consultation with.
That's a good point. So other thoughts here in terms of, yes, sir. And I would invite Dr. Khanna, who might have an interesting perspective on consumers, if you're able to comment here.
Yeah. Actually, David, I'm not sure which section we're talking about. Is this about the originating site?
So we are looking at removing telehealth restrictions on originating sites, and we're at unintended consequences, the impact of this on consumers.
Yeah, so I think that having restrictions on who can initiate the conversation is needlessly restricting for both patients and for providers. I really hope that we don't make originating site as an issue, whether that be the provider home or the provider office, or whether that's the patient based outside of Maryland. I think they should be allowed to reach out to physicians in any which way they can. And I think for the duration of the COVID pandemic, definitely that would be applicable. And in the future, I would suggest we seriously consider allowing this to be a more liberal account in this.
Okay, very good. Thank you, Dr. Khanna. Jim Hummer, do you have any views here you can add as well from your perspective?
I just typed in the chat box. I think we had a listed above for providers in the possible negative relationships. If there's variable providers, that one time versus continuity, be the same for the consumers. If they're seeing a different doctor every time they've got a problem because they're just calling into a big group, versus establishing a relationship and having consistent follow-up, getting better quality, where a physician with the relationship is going to start to recognize different things. So.
Very good. Thank you for that. So let's, if there are no additions to this particular quadrant, let's travel along to the permanency concern. Again, we're looking at it from the perspective of starting with the providers here, and this relates to permanency concerns. So let's pause for a moment while everyone takes a moment to review the list and see what's there that needs to be added or what we might need to take out. Okay, so Oleg, your thoughts on what might be concerns related to permanency here?
Yeah, so I would echo what Matt said earlier and others in terms of data. I think to make anything permanent, we have to have enough data and analyze that data appropriately within the context of both the experience and the events that are all around us. And so for that, we just need time. I think almost ironically, as we're looking for permanence in some of these, we need more time to figure out whether permanency is necessary. And if it is, which part of these efforts should be made permanent and which parts should stay sort of on temporary basis.
Very good, thank you. So traveling along then, others on the call, what do you all think around permanency concerns for providers? And Dr. Berman, any concerns from your perspective?
Thank you. Certainly I agree with what people are saying with regard to needing data. But I think the issues that we're talking about with regard to telehealth are here to stay. It seems to me that as horrible as it is, COVID has given people an opportunity to really benefit from the use of telehealth. And my hope would be that the changes that we are talking about would be permanent and afford a variety of options for consumers in Maryland.
Good point.
So David, this is Matt Celentano. I agree that we are not going to go backwards with all of the changes that have happened to address the pandemic. That is for sure. There are things that are here to stay, but you know, it does give me a little concern, some of the wide sweeping changes. I mean, I can just tell you from a personal point, there has probably been 25 to 30 telehealth visits in my house alone between COVID and some children health issues. And I got to say, it's all over the place. Some of them have been fantastic. No doubt about it. I have felt like I've been taken care of and my kids have been taken care of. And then there have been some that have been complete disasters. And there is no control over it. And there's no guidelines. And we are all doing the best we can, like I said, to react to a crisis. But to sort of ignore some of the concerning telehealth interactions that I've had in my house, and I've heard from lots of folks, and we've heard some concerns about complaints to some of the boards. I just don't, I want to just caution against jumping forward without knowing the total impact of what we're all dealing with.
Yeah, good point. Fair. It seems reasonable.
David, I would also, add the point that the originating site is really a Medicaid feature, but who decides what's a permitted originating site is an important question as we move forward. Is it the clinician? Is it the patient? Matt seems to be suggesting that it's not a payer or a commercial payer concern right now, but the choice is not necessarily no restriction on originating site and a relatively defined restriction that exists only in the Medicaid and Medicare worlds, that someone will have to make that call, even if it's stricken as a requirement under Medicaid and Medicare. One would hope that it's thoughtful clinicians in consult with the patient, but we shouldn't lose the fact that someone still has to make that call about what's appropriate. And our colleagues in behavioral health, I'm sure, can attest to situations where patients, while they might benefit from a face-to-face visit, just don't want to do it. And they have to use their clinical skills to encourage that to happen. And I think by saying no originating site, we're deceiving ourselves. Someone has to decide.
Yeah, good point. And Ava, why don't we instead of putting that under consumers under other, just add a heading under there that says other. It can be other. I think Ben's bringing to light a good point that we don't want to commingle necessarily. It's more overarching. Thanks, Ben. So any other additional items for the providers?
Jeff Sharp, can I make a comment, please?
Please.
I want to make a comment on the statement here. It says, consider one patient-provider visit before telehealth to establish relationship, limit the loss of local providers. So first of all, I think in terms of telehealth, if the idea is to increase access to chronic disease management, to increase access to preventive services, make sure refills happen on time, I think that sort of visit is needlessly restricting. And for the multitude of primary care folks who work in urgent cares and immediate cares, who fill a critical need, this sort of requirement for one patient provider visit basically eliminates the urgent cares from using telehealth at all. So I would caution that we rethink that and we really consider the needs of patients first. We try and put patients here and try to think about what do they need. So from my perspective, I would say that it would be major restriction and not something I would support.
Okay.
David, this is Sally. I would like to echo what Narika said. One of the things that FQHCs have found as we've been able to use telehealth is that patients that we've been able to heretofore unengage, some of them have been enrolled in Medicaid 2 or 3 years and been unengaged despite, I would say, 100 to 200 attempts to outreach to them, we've been able to engage them. And we've been able to start the conversation, to begin to develop the medical history, to send them to a lab, to go over their medications with them. So it's been a very valuable tool for us to begin that engagement process. Because one of the things we know about some of our Medicaid patients is you have to talk with them 2 or 3 times before they begin to trust the system, you know, trust the provider. They have other priorities sometimes, or they're not comfortable with the system, the larger system. So I agree. We need to not make this needlessly restrictive. And I also wanted another comment I wanted to make is we have guidelines in place. Medicaid has quality guidelines. Medicare has quality guidelines. FQHCs have HRSA quality guidelines. We have our respective boards have guidelines. So I don't want to see us go down a road where we begin to overstudy and overanalyze when we already have things in place. And we just want to make sure that providers practice within their scope of work, within the current quality guidelines, and just reinforce that a telehealth visit, equates in many ways in terms of quality of the visit and stuff to what we already have in place for an inpatient visit. Because again, keeping in mind that few of us were doing much in telehealth prior to COVID, all of a sudden overnight, in order to be able to take care of our patients, we had to develop new technologies, both for ourselves and for our patients. So, there has been a lot of ups and downs with it. I think if we get some good guidelines in place and things, this will smooth out and it will become a good option for particularly the population that I'm concerned which is the low-income Medicaid population.
Yeah, thank you very much. And I think as you were speaking, Sally, and a couple others weighed in that also support Dr. Khanna's point. So let's jump back to providers and make sure there's nothing else missing. Dr. Lawson, any additional comments? And as you're thinking, I would also ask Jean Ransom, if to be ready to jump in here from your viewpoint, and then also if we can get the viewpoint from our colleagues at the MHA, Jennifer Witten. So we go in this order if we can. Dr. Lawson.
Hi, David. No, I don't have anything else to add. I think at least from the providers, from our perspective, it's captured already in what's on the list.
Wonderful. Thank you. Jean, are you able to comment? Okay, we may have lost Jean briefly. Jennifer?
David, we're still on originating site discussion, correct?
Yes.
So I think we have debated this in great detail. I actually would agree with my great colleague, Matthew Celentano, that there are some issues that perhaps should be under a miscellaneous item, but I think we've covered this quite well. Perhaps we should move to the next bucket so we can get the work done as you encouraged us to.
Sally, Ann, were you ready to make it? Were you preparing to say something else? I wasn't sure.
No.
Okay, very good.
I was getting a drink of water.
So let's travel on to payers under the permanency concerns and see what perspectives we have. So let's take a moment and just read the list. Okay. Comments here. Tricia.
So I think you have it. I mean, as you say, Medicaid has been providing these services in the home. As we mentioned at the last meeting, we can't ignore what Medicare is doing in this space because so many of our individuals are covered by both Medicare and Medicaid. And it's very clear that the recent guidance from CMS says that if Medicare denies those payments when they're supposed to be the primary payer, that Medicaid will end up paying the entire cost of the service. So we can't ignore what Medicare is doing in this space around originating sites. We have to be conscious and consider what is being allowed and permitted on the on Medicare benefits. I will say, just again, I'll reiterate that, we are a bit unique. We do cover residential settings. So I'm not, if someone is at home, you're not going to have a residential provider providing services to individuals in a home setting. So, so I just caution again around broad language that's getting rid of originating site when it's when we in the Medicaid space, because again, those residential providers aren't being covered under the commercial benefits. So anyways, although again, we have very much in support of the home setting, but we need to again take into consideration what Medicare is doing in this space, as well as the unique benefits of Medicaid.
Okay, thank you, Tricia. Kathleen, your thoughts?
Yes, thank you. I don't have anything to add right now.
Okay. How about Kathy Grayson? Are you able to weigh in?
Sure, we don't have anything to add on this either. Thanks, David.
Very good. So for the entire group, are we missing anything under payers? Anything else that
Hey, David, this is Oleg again from Care First. Just to bring folks' attention to the what's known as the telehealth waiver 1135. This is from CMS. They have included patients' residents within the definition of originating site. And I'm not sure if that was a permanent rule, but as far, I believe, as the health emergency is ongoing, that rule is still in effect.
Yeah, so
it's my understanding again that that's just for the emergency period, but I think Medicare is going to probably make changes as well after the emergency ends, but again, the current authority is only during the emergency period.
Okay, thank you, Oleg. Appreciate it, Tricia. Anyone else?
David, I have a question for the facility fee. If the provider are they get paid for the facility fee, or it's gone away because of telemedicine? So if the provider is not in the facility, they are doing from home or somewhere else, because which I know some of them are doing. Are they getting facility fee? How it works?
So yeah, David, this is Matt Celentano from the League of Life and Health Insurers, and this is a concern that's been raised by the commercial carriers that operate in all 50 states too, as they do not want to see facility fees tacked on to site folks that are having telehealth visits in their home.
So
right, then how do you know they are doing from home rather than the facility? I think facility fee, if the patients are not coming in the facility, are they allowed to charge facility fee? Irrespective of where they are, doing the televisit.
So, Ava, why don't you add a concern about facility fees under payers? And I think Dr. Bandari and Matthew bring up a good point that we shouldn't lose sight of. Okay. Anyone else comments here? If not, we will move on to our consumer group to see what the thinking is. So it should only take a moment to scan through this, and then I would turn to Ellen to start us off.
Thanks again, David. I mean, I think the only other thing to add here is the recognition that that there does have to be this continued, financial support to ensure that all individuals, regardless of where they are, will be able to have access to telehealth in their homes on an ongoing basis, and that that infrastructure is developed to avoid perpetuating a two-tier system. I think that's been raised in various conversations.
Yeah, very good point. Jim, do you want to step in here as well?
I don't have anything to add at this point. I think the financial support for infrastructure for patients is a key point here.
Yeah, that's very true. Others?
Hey, David, can I just follow up on those two comments? Is it suggesting that payers pay for that technology? I just want to clarify the comment.
So Ellen or Jim?
Okay. AARP has not taken a stance on that, so I wouldn't want to say anything, but we recognize that this in some way could be a substantial cost.
And the same for us. I mean, I think the one has to take a look at what those costs are and how to support that. But there does need to be thinking and plans put into place for that. And again, I'll leave it at that.
Yeah, and from the perspective of others who may not be aware necessarily representing consumers, but are there any thoughts to this point that's being raised at the moment?
Yes, I do have a comment. I'm Daniel Mansour from the School of Pharmacy at University of Maryland. Hi, David. Good to see you after a while. Just a quick comment, because we do serve two underserved, underrepresented people in two high-rise buildings in West Baltimore. And one of the things that popped out during trying to do comprehensive medication reviews is the fact that some people don't have minutes on their phones. And so even connecting to a phone, let alone a video, is becoming a challenge. So tying this into the financial picture, I'm not sure if something could be put in there to, especially with older adults, they're deprived of medical care just because they don't have minutes on the phone. So I just wanted to put that out there in whatever category you feel comfortable with.
Mansour, it's very impactful. Okay, anyone else before we move on?
Just an anecdotal comment, and to a certain extent, I think this is covered under the final bullet point under providers, but just sort of along the same vein, customer satisfaction and feedback data would be important at some point. Right now, it's a matter of necessity, and I like Matthew's example earlier, about 25 telehealth, visits since we've been enduring this pandemic. At some point, I mean, hopefully once things settle out a little bit, we actually do then need to get to a point where, with some of the other discussions we've had in terms of, delivering quality care and, utilizing some sort of consistent guidelines or expectations to drive the delivery of telehealth, we'll need some data, so once again, it's anecdotal because we've talked about data to a certain extent, but we would need customer feedback data at some point to continue to drive these efforts.
Yeah, excellent point. Thank you. Okay.
Hey, David, it's John Kornak. Just to Dr. Mansour's comments earlier around population, obviously a lot of the grant opportunities have been really more to FCC, and those have been more for the rural areas rather than looking at inner city where there is a potential risk on digital divide and that kind of stuff. So having those grant opportunities or those financial opportunities not just being in certain locations, but it being restriction free of either inner city or rural. So not sure where we want to make that comment, but those are some of the issues that we've kind of seen, is that it's been demographic restricted.
Yes, understood. Very good point.
So, David, I think we have a pretty good list, and we could certainly come up with some additional, but I think we want to be cognizant of the time. We have about 40 minutes left, and maybe we push ahead on some further into the deck.
Okay, so it's a great point. Thanks, Ben, and everyone else. So let's just pause for a moment and see if folks can read the other quadrant, and if there's nothing else missing, or you think we need to add, we will continue on to the next policy statement. So we'll pause here. Okay, any comments? Okay, let us move on. So we're going on to the next item, discussion item, and that is permitting audio only when treating providers determined to be safe, effective, and appropriate. So we have a pattern down based upon our experience in going through the first one. So we'll try to use the same approach going into this particular policy question. So first up are providers. Let's take a moment to see if anyone has any questions. And what we can do without, if this doesn't create the risk of confusion, is broaden the comments to the entire cell. So if you read the two, both providers and consumers, and you have thoughts you wish to add, we can collect both of them at the same time. That might help in the interest of time. I think Ben's kindly kicking me along a little bit, saying, pick it up, pick it up. So message received. So you all have to help me out here. Do you all think the list is adequate, or is there anything missing? And by the way, we don't have, somebody pointed out earlier that payers was missing from a particular cell. If the payers feel that there's something, or any stakeholder feels that we need to add a category for the payers, we can do that here. Okay, any comments, questions, concerns? Okay, hearing none. Let's go over to the unintended consequences, and let's use a similar approach. So I'm not sure if I've scared us away by trying to quicken the pace, or no one really has any comments. So I'm looking at Rebecca, and I just want to make sure that that's the case.
Oh, it's good. I just had questions about the risk for siloed care.
Okay. And is there something on your mind? Is there, what do you?
I'm just looking for the background on that. Is that people are afraid there'll be phone calls that don't have documentation, and so it won't fit into the continuum of care? What are folks thinking about here?
So let me give you a little bit based upon what we understood. The siloed care in terms of the technology integration, in that if it's audio only, there was a risk that the what's discussed doesn't adequately get represented in an electronic health record, doesn't get is not in any way able to be shared with other providers. So there was some concerns about creating a technology silo by you just offering the use of telephone.
So it has to do with documentation into the EMR?
Yes.
But David, my understanding is we are documenting for these phone-only visits.
Yeah.
Actually, that at least I'm doing that.
I haven't heard of
You have to have a documentation you have
which
done.
is why I question it.
Okay. So we've noted it with a unique color, so we'll go dig back into it to see. And whoever wrote this comment, if I've misstated your concern, please jump in. And I think Dr. Merkin, I believe, I can't tell for sure if you were going to add a comment here or not.
Yeah, hi, sorry. I actually looked at box 3 and I think that's the one I want to comment on more. So I'll just wait till we get to box 3.
The permanency side, gotcha. Okay.
So this may be something that we need a little bit. It's our representative from American Well still on.
John.
I'd like to pose a question to him.
I think John, are you around still? We may have lost, I don't see him on the list. So
Okay.
I may have dropped off. Then we can follow up with him offline.
Yeah, I mean, maybe someone else wants to venture into this murky area, which is, I think audio only is a service. Audio only in this is post-pandemic, might be a service that needs to be reimbursed. I wonder if it's different than telehealth. And I thought a purveyor of a telehealth platform might have some special perspective on this. But I'd welcome other folks' comments on this. It's pressed a couple of years ago. We probably would not have put it within the constellation of telehealth services. It's benefited because it's for many cases today the only option, but it does strike me as it does somewhat complicate the definition of telehealth, especially if we are moving it as a technology forward to say it is constrained to audio.
So Rebecca, do you want to weigh in so your comment can be heard by everyone?
Sure. So we have very strong feelings about reimbursement, that it should be paid in parity based on provider time. And I think we look at audio only as a pathway to perhaps the only care a patient can access.
And I will echo that in addition to just talking to the patient, there is a lot of background work need to be done.
Mm-hmm.
Look at their labs, look at the scans. We talk to other providers, either their primary care or other specialists, whichever time. It still takes time, which was unpaid until 2020.
David, this is Sally. I would agree with Rebecca. This is generally either the patient option for a number of reasons, technology reasons, privacy reasons, whatever. Or sometimes it's the only way to engage the patient. So I agree with Rebecca.
Thank you, Sally. And I think, Jean, you have a comment. Are you still experiencing technology or issues, or can you weigh in here?
Jean can go to audio only, maybe.
Jean's comment reads, we strongly support continuing and expanding audio payments for all specialties. Okay.
And Jim Gutman has his hand raised.
Oh, Jim, good afternoon. Please go ahead.
Just in the consumer side of unintended consequences, I don't see anything that says that this may not be right for certain patients and certain conditions or illnesses, and I wonder if we should have something that explicitly says that.
Okay. Thank you for that comment. Okay, so I'll pause a moment to see if we're missing anything from this list, and then we'll go on to permanency concerns.
Hi, David. This is Kathy Grayson with Care First. I'll just mention. Hi, David. This is Kathy Grayson. I'm sorry, it's me. I'm on echo myself again. Is that better?
Yes.
Nope. I'll just add, this is another section where we wanted to emphasize the importance of having more data on the long-term implications before making an abrupt policy change. We had suggested that as an unintended consequence and also just as a permanency concern. I didn't quite see it on here, so I wanted to just throw that out there.
Okay, we'll make sure we capture that. Ava, you're going to add that in. And then we're going to go on to the permanency concerns. Okay, let's pause a few moments, give everyone a chance to read the list, and by categories and type, let's see what's we're missing or what we should change. Okay, who wants to jump in? Jim, from your perspective, anything from the provider side or the consumer side? Jim Hummer?
I don't know. I was getting back to that comment around parity for provider time, which I would certainly agree with. But and I think it was mentioned up above about the potentially disincentivizing investment in continuing to develop video capacity and capabilities and access if we're reimbursing audio only. But is there a level of reimbursement for audio only, or audio plus video, or audio plus video plus health readings that gives more information to the provider? Yes, it's the same amount of time, but does it improve the quality, or somehow have an incentive for providers to get different and expand tools that are available to the consumer, so that now I have an incentive to put a tablet with some remote patient monitoring equipment in their home, because there's enhanced reimbursement for that type of call versus a telephone. And the other thing I was just thinking, because we run into it too, even with technology, because it's, it's good at times, but not at others. You can be doing an audio video call that turns into an audio call. Because you lose video or you lose some other capabilities, and is that still a reimbursable visit? Because you could probably still have a quality outcome from that.
Yeah, okay, very good point. Thank you, Jim. Dr. Bandaria, were you going to make a comment?
I think, as Jim said, the issue is, for the having we start with the video, and a lot of time the connection is poor, and then we end up with the audio. The consumers need to know there is some co-payment also involved. I think those things need to be clarified, because that's my concern. The patients need to know this is like in-person visit. We spend a lot of reading. We read them, this is what get their consent for the audio as well as video. I agree with that. Identification of the patient may be difficult. Maybe we have to take their word and see they are the right patient. Otherwise, this looks good.
Okay, Dr. Merkin, I believe you were going to add comment here as well.
Yeah, thank you. I actually meant box number 3, the next one. The removing telehealth restrictions on conditions that can be treated.
Oh, I see. Okay.
Yeah.
We won't forget you as we get.
Okay.
Okay. Anything else missing here, or does the list look as though it's complete?
David, are we still on providers?
We are on providers and payers, so we can bounce back and forth, Matthew.
Okay. I would love to chime in, I guess. Well, I don't know about love is the proper word, but so I think there are a lot of questions about the policy of reimbursement that I don't know if we're going to be able to solve today. I don't know if we're going to be able to solve in a couple of months. I think that there are certainly reasons to believe that audio only would be appropriate in some areas, and then video would be others. But ultimately, we want folks to be seeing their providers in person at all, whenever possible. And we have seen lots of studies from various institutions, including the Johns Hopkins School of Public Health, that shows that the care is much, much better in an in-person setting. Now, that might not be the case for all providers, but I think generally we want to encourage folks to go see their provider in person. So with that being said, it is hard to sort of set up a reimbursement scheme that would be parity if we're trying to incentivize some kinds of behavior. And I think it would be problematic to try to shift reimbursement strategy to address the pandemic when they're still in the midst of the pandemic. I'd hate to be sort of like beating a dead horse, like I've been saying before, but to make these kind of changes in the midst of the crazy surge, and we've increased 150 hospitalizations in the previous 3 days, seems a little wacky to me. I don't know if paying less for audio is appropriate than video, or if a combination of both should be the same. But I don't want to get ahead of ourselves and change wide sweeping policy that will have impact on cost across the board in the healthcare continuum without having enough data to really determine what's appropriate. So I would just once again urge caution.
Yeah, thanks. And Ava, on that bullet point above, if we could add in brackets around, just put payment parity of question, and we'll know to come back to that as well. From the payer standpoint or the provider standpoint, any additional thoughts? And then,
David, I have a suggestion for Matt. Do you think there should be some guidelines from the payers to the providers and say, look, with the audio only, this is what we want to have, some documentation or what you have done? I agree with you, your concern as a payer, but if something is given to the providers, that may be helpful.
I think that's a fair discussion to have, and I don't want to speak on behalf of each one of the individual companies. I know that there are a lot of carriers that are having discussions with some of their contracted providers, and those are sort of business decisions. But then as the wide sweeping statewide policy goes, we're just time will tell. And I think that we will figure out what's appropriate once we are starting to get to a point where we know what has happened since beginning of March, or maybe even earlier if we really want to get truthful about it.
Dr. Schaub, can I speak to this, please?
Dr. Khanna, please.
Okay. I want to make sure as we develop an access strategy for patients that it remains patient-centered. I also want to make sure that we don't establish new prior authorization criteria for a service such as this, which is designed for access. And I want to be very clear that the determination of whether there should be an audio call or not, or it should be a video call, needs to be done between the patient and the person taking care of them. I don't believe I'd like to be told by any insurer how I can connect with my patients.
Yeah, and
Dr. Khanna, I echo your comments.
And if I may comment, David, this is Paul Berman.
For Dr. Berman, go ahead.
Thank you. Yeah, so the only comment I want to make is that I don't see that we want to encourage patients to see their practitioners in person. It seems to me that's not the marker, that the marker is good care. And good care and appropriate care maybe telehealth, because it increases access and increases appropriate use of services. And in the same way, it may be that for some individuals, audio only is the best way to provide care for that person, because they don't have access to cars, they don't have access to services in other ways. And so it seems to me the determination about appropriate treatment is not in person, but it is what is appropriate treatment. And the concern is the focus being on in office. It seems to me, again, that's not the determination of quality care.
So Ava, can you jump over to the other category and add another title that says other? And I think Dr. Khan and Dr. Berman brought up some good points about it should be based upon the patient and provider discussion or need. It should be a patient-centered focus, and let's start there, and that'll help us in the notes when we come back to it. So thank you all for those points.
David, this is Ellen Weber. May I just say, make one response with regard to the issue that Ben raised with regard to the payment structure. I guess I just wanted to add that that at least the 3 states that we're familiar with and that have gone in Medicaid to audio only outside of public health emergency, even though we're still in that. But in contemplating that, their policy decision was that it should be parity with in-person visits, that there would not be a distinction between audio only and audio visual or an inpatient visit. And so I just wanted to put that in the discussion, because there are already decisions being made around that.
So I will say, this is Tricia Roddy. I think we're not necessarily on the same page as the other states. And again, where the other states weighed in at this point is at the state legislative level. CMS has definitely given guidance to states that they can set their own payment policies around audio only and telehealth. And I do think we need to look at that very seriously. Maryland is a bit unique. We have the hospital regulated services. We need to figure out how we deregulate these services when they're not in the hospital setting. And so that's a big, large discussion. Do you think it needs to be put on the issue list as we're moving more and more to increase telehealth and also discussing audio only provisions?
So Ava, that goes under other, so it's deregulating.
So I kind of want to I'm trying to get everyone to think hard about this issue of parity, and I think Jim Hummer did bring out a point that the idea of parity with telehealth, with audio, video, and what else may be coming along may actually be short-sighted, because it hamstrings the development of technology. I think we're looking at it from the standpoint of audio. Yes, audio needs to be paid the same as face-to-face and audio video. But as technology sweeps forward, the features of a telehealth visit are going to change. And we have to be thoughtful about insisting that reimbursement be equivalent for all modes of care, when in fact, I think arguably for most services, audio video is the preferred mechanism. I will couch that by saying there are certain circumstances where that may not be true, but if technology is equivalent, we would I would think, opt for audio video, and if possible, the technology devices that could accompany that telehealth visit that would allow in real time a clinician to assess the patient condition. So by insisting on parity, we might actually be hamstringing the reimbursement system, to limit the expansion of to pay for technology that it is desirable for the health system to pay for.
I think, I can't tell for sure, but Dr. Bandari, were you preparing to make a comment here?
Dr. Sharp, I already made a comment.
Okay.
Thank you.
Very good. Okay, these are very good points. Anything else under the permanency concerns? Other payers that wish to weigh in? Kathy, or
Nothing here from Care First.
Kathleen, anything?
No, but thank you.
Okay. Okay, we'll just pause for one more moment to see if there's anything else you want to add for the permanency concerns, and then we'll travel along to the other category. And
David, I would just like to comment again that, at least for us, the choice is always an in-person visit. And that's what our providers prefer. Probably next in the rung would be an audio visual, and then, audio. But audio visual and audio, you need to be on parity, at least from my perspective, because often an audio only visit is not necessarily our choice or even the consumer's choice to have a video visit. Our rural health centers have very bad broadband access, and we have lots of evidence of, in the middle of a video visit, losing connection and that sort of thing. I don't want to open the floodgates, but at the same time, I want to, a recognition, advocate for a recognition, as Dr. Khan has said, this is between the patient and the provider. And what is the best opportunity to engage and care for that patient. We entrust that to the provider and in-person visits. And now there seems to be a different standard because we're changing the modality.
so I think, Ava, the bullet point here is the decision should be left between the patient and the provider. That's a key takeaway. Thank you, Sally Ann. Jennifer, there are a number of folks who are joining us on the phone. Could you just paraphrase your comment for everyone?
David, I think I was just making a note, commenting to Tricia's comment around deregulating hospital services as it relates to telehealth. I think there's a nuance there that some services are rendered through specialists and in the hospital that should continue to be included under hospital rate regulated services, and others that are part of provider groups that should not. So it's a little bit more nuanced. That was my point.
Yes, and thank you for...
And so, David, I just want to comment too. It's my understanding that in terms of regulated services from HSCRC, so it'd be good to get their input in this as well, is that in order for it to receive the regulated rates, the service needs to be provided on the hospital settings in their regulated space. Otherwise, they don't have the authority to provide the regulated rates. And then secondly, Medicare doesn't pay the facility fees, and generally we don't want to pay facility fees as well. So I think the overall discussion around deregulation needs to occur.
Yeah, good point. And that is my understanding as well, but we'll be sure to engage with our colleagues across the way to clarify.
And I would just ask, perhaps maybe, David, that gets added to a comment section, not directly related to audio only.
Understood. We will call it out. Thank you. Okay, so we are less than 10 minutes on the hour for the end. I don't know that it makes a whole lot of sense to start a new section, but let me just ask the group if there would be any concerns if we ask you all over the next week to look at the list more carefully based upon not so much two, but look at the questions or the policy statements, if you will, in items 3 through 6, and provide us with anything that's missing or any concerns that you have, or if there are any changes that you might propose. We can speed this along between the meetings if we can task you all with a little bit of homework in between. We think we got a pretty good list going from the work that everyone contributed between last meeting and this meeting. So that would be our ask, and we'll send that out with a bit more guidance. And hopefully everyone would be willing to weigh in there. And then we will be able to speed things along. If there's something specific and you want to just shoot us an email, we can add it that way, but we'll send the tables back out. And Dr. Merkin, my apologies, we didn't get to your comment this evening, but you're welcome to either type it in an email or add it to the tables when they come your way.
Okay.
Okay, so with that, we want to turn back to the agenda. Before we get to next steps, I would invite our commissioners and our executive director to make some observation or comments here.
Dr. Bandari?
I think it's a good work in progress. Actually, this is my first meeting, and last one I watched online the recording. This is good. I think it's going to take some time, but we are making progress in the right direction.
Perfect.
Dr. Quintada?
I also appreciate that this creates an opportunity to bring stakeholders to the decision-making table. So I think this was great. This was also my first time at this meeting. So thank you. Thank you,
Dr. Alcantara and Bandari. Appreciate the thoughts. Ben?
I think I appreciate everyone's thoughtful comments today, and we'll look forward to continuing to work with the group over the next steps.
Okay, thank you, Ben. Ava, are you able to weigh in? I know you were having some audio challenges earlier. Let's try, and if not, Justine is online and ready to jump in.
Or are you able to hear me?
I think Justine, sorry, it's broke up. Justine, can you take us through this?
So, hi everyone, I'll cover some next steps. So the work group is set to reconvene on December 10th virtually from 3 to 5 p.m. Ava will be sending out a calendar invitation shortly. Before the next meeting, you'll also receive an email with a link to the recording and a high-level summary of today's meeting. You can find all of the recordings for our meetings on our website. Thank you all for joining. We appreciate your time and look forward to continuing the conversation next month.
And look forward to feedback that if you're able to provide us on the tables once you receive them. With that, everyone, thank you for your time. Thanks for the great discussion. It's wonderful to see you all, and we'll look forward to talking to you more about these policy questions as we get into December. Have a great rest of your day.
Thank you.
Take care, everybody.
David, is there any other comments in general? Whom should we address, rather, in addition to the survey? Send it to Eva?
Yes, please.
Wonderful. Thank you.
We will.